So the first-line BRAF wild-type patients group has options. And as always, the decision comes down to balancing risks and benefits. Obviously, there are no current standard of care targeted therapies available to us for this group, even the NRAS mutant group. So the decision comes down to single agent or combination immunotherapy in practice. As the data have emerged, the thought process has flicked back and forth between explaining why a patient needs combination therapy versus justifying why you wouldn't give them combination therapy. And because we now have more than just ipilimumab plus nivolumab in our combination basket, I really don't think this debate is going to end anytime soon. So the single most influential study addressing this question was Checkmate 067, and that compared ipilimumab plus nivolumab combination or nivolumab alone with ipilimumab alone in nearly 100 treatment-naive advanced melanoma patients. 1,000 treatment-naive advanced melanoma patients. Notably, the study was not designed to compare the two nivolumab-containing arms directly head-to-head, although obviously some numerical comparisons, if nothing else, have been done subsequently. The data suggests that there is little, if any, additional benefit from adding ipilimumab to nivolumab in BRAF wild-type patients, thus favouring the use of single-agent anti-PD-1 in that group as a broad generalisation. Now, there are some very strong caveats to that generalisation, though, as I don't think it can be said of patients with brain metastases, in whom combination ipi-nivo remains the treatment of choice, based on data from the ABC study that we discuss in the brain metastasis topic. Other high risk factors could also contribute to the decision to go for combination therapy, even in a BRAF wild-type patient, such as the number of sites of visceral involvement, particularly more than 3, the burden or tempo of disease, which is hard to quantify, the elevated LDH status, specifically more than 1.5 times the upper limit of normal, and the presence of liver metastases. Even considerations of drug access, whether that's current drug or projected future options in the event of failure of the current regimen, may be relevant to the decision about what therapy to choose in the first line. I also find that patient preference is important. Younger, fitter patients may be keen to try the strongest regimen we've got. And in some cases, a higher response rate might be desirable based on the specifics of the location and the burden of disease, or a perceived window of opportunity in patients who are rapidly deteriorating functionally. So combination therapy typically affords a higher response rate. In Checkmate 067, objective responses were seen in 57.6% of combination patients, 43.7% of nivo patients, and only 19% of ipilimumab patients, although interestingly, that is somewhat higher than seen in the paradigm-shifting phase 3 study of ipilimumab versus placebo. So these differences might be relevant to patients for who structural reasons mean that they really would benefit from medical debulking of their disease. But importantly, while there are differences in the likelihood of achieving an objective response between these regimens, there is no convincing suggestion that one regimen achieves a response faster than another. So that really shouldn't be one of the determining features in treatment choice. Prior therapy is also quite relevant. Patients who have relapsed despite seeing prior anti-PD-1, such as in the adjuvant setting, would be quite unlikely to respond to re-challenge with the same regimen. So upgrading their regimen to a combination therapy makes sense. And we discussed that more in the post-PD-1 therapy topic. And lastly, toxicity. Again, always one of the key factors in deciding what treatment is most appropriate for any given patient. Because combination regimens certainly have a higher risk of side effects than single-agent anti-PD-1, and single-agent ipilimumab is somewhere in between, with a particular propensity for GI immune-related adverse events. So we have to balance the potential benefit against the potential risks. In the absence still of any reliable biomarkers to predict immune-related adverse events, in most patients, I take the pragmatic approach of considering that the level of risk is a constant feature of the regimen, whereas the level of potential benefit is proportional to both the regimen choice and disease or patient-related factors. So patients with a known history of autoimmune disease present an additional risk of immune-related side effects, with flare of their pre-existing disease or another organ system related event. Conversely, patients on pre-existing immunosuppression may have a lower than expected chance of benefiting from the treatment, with an uncertain impact on whether that alters their risk of toxicity. So I think, again, it always comes down to that balance for an individual patient of the likelihood they're going to benefit from any particular regimen weighed up against the likelihood that they'll experience intolerable side effects.